So we've heard about Clot 1 and Clot 2, and now we'll hear about Clot 3. So we'll bring Elliott Haut back to the stage, and Elliott's been doing some excellent work.
It's mostly preventable. We've heard a lot of talks about the preventability here. Here's a small paper that Mike Strife, who's a hematologist, and I wrote, which looks at just some of the orthopedic joint replacement studies. In the best practice studies, in the randomized trials, events still happen. So even if you carefully select patients and give them best practice and know they're getting these meds, events still happen. They're not all preventable, and they're not never events. So we've heard a lot about all the evidence-based guidelines that are out there. Some are specialty-specific, some are more broad, some have been from one organization, they've switched to others, et cetera, but there's tons and tons of evidence out there. And we, there's even a little bit of evidence. I know Pat Murphy's here. Pat, I told you I'd show you this paper about emergency general surgery. Many of us do trauma and EGS. There's lots of different data out there about what we should be doing. But we also know, and this goes to the question that Deb Stein asked earlier, know what to do, and the evidence is out there, and the question is, why don't we do it? Here's a study, it's relatively old now. Patients with DVT, 42% had received prophylaxis. Okay, pretty bad. Here's another study. This is a multinational study. It's now, over 10 years old, 68,000 patients, 350 hospitals. Surgical patients, 60% of the time got appropriate prophylaxis. Medical patients got it appropriately done 40% of the time. I joke all the time that, hey, we're surgeons, we do better than the medicine doctors, but it's still pretty bad. We're 60%. We know what to do, and as Deb Stein said, why don't we just do it? American Public Health Association. They don't usually talk about DVT PE, but they did. They put out a white paper about the disconnect between evidence and execution is a public health crisis. Right? We should be doing a better job. AHRQ in the past has said that DVT prophylaxis of at-risk patients is the #1 strategy to improve patient safety. We should be doing better. Here's a more recent update. The top 10 strongly encouraged patient safety practices. On this list, things like hand hygiene, but DVT prophylaxis is on the list. One of those top 10 items that we should be doing. We wrote the paper about prevention of VTE and gave a brief update on the benefits of using appropriate prophylaxis to support that AHRQ recommendation. So we have to do a better job. So the topic for now is how do we do a better job in the inpatient setting? And I want to talk a little bit about systems improvements to try to get to the point that Deb, like I said, has mentioned already. We know what to do. How do we make it happen for every single patient, every single day, every single time? Dr. Geertz gave us some ideas of putting it in order sets, and I'm going to show you a little bit about how that might work. So what approaches improve VTE prophylaxis? This is a systematic review. It's like probably a decade old now. And it basically passive dissemination doesn't work. Just teaching people and telling them that they should do a better job doesn't work. You need active strategies incorporated to remind clinicians to improve the care that they provide, both for DVT prophylaxis, that's what we're talking about today, but probably for other things as well. We know that. We wrote this paper, and it's lessons learned about how we change practice at a big monstrosity of a painful academic medical institution that many of you work at. It's really hard to change practice to affect the care of neurosurgeons and orthopedic surgeons and nurses and doctors of all different specialties. So if you're interested in a quick, easy read without much data, I would suggest this is one place you could look. We started with paper order sets, right? So now when we think about it, oh my gosh, how painful was that? But that's all we had at the time. We had these paper order sets. They're very cumbersome. They're very painful. For those of us that did fellowship at Penn together, I saw Brian over there, right? We had the little laminated card. You take out the laminated card, and it would tell you what to do, and that's what you would order, right? It's the same idea of paper order sets. It works, but there's probably better ways. We then put it into our mandatory risk assessment, and AJ told us a little bit about the importance of risk assessment as a first step. Stratification, we put it into our computerized order entry system, and we put in some decision support. At the time, it was relatively advanced. I think this is a decade ago. Now we're doing much more decision support, but at the time, it was kind of cutting edge. And this is kind of what it looked like. Here's the order sets. You've all seen things like this. There's the order set. There's a VTE part. If you unclick the VTE part, you can't do the rest of the order set. So you can't do all the other things you need to do. So it was a great forcing function to make you do the risk assessment. So here's a typical algorithm. Nobody really likes this. Like, the average clinician doesn't love looking at this. You know who loves this? A computer programmer. So if you give this to a computer programmer and make your life easy, then all of a sudden, you just get a few checklists. And then, I worked with Peter Pronovost at Hopkins. You make it a checklist, click, 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 and then up pops the answer of what you should be giving. And then we can follow, did they or did they not give it? So the benefit of this decision support built right in at the time of use is how we can change practice on a day-to-day basis in our hospitals. Puts the prevention right in the workflow that the residents are doing, rapid risk assessment, applies evidence directly to patient care right at that moment. And I'm going to show you a little bit about how it can allow for performance monitoring. So the key is a multidisciplinary team. We already talked about it here today. We've got a multidisciplinary group here. Same thing I have back at Hopkins: physicians, nurses, pharmacists, informatics, et cetera. Leadership buy-in. I already told the story that the dean knew exactly who I was for a good thing, not a bad thing. Collaborated with the ortho, neuro, et cetera people, educated the frontline providers, and then measured data, measure, and then remeasure to see how we're doing. So I've got two quick papers to show you the benefit of this. One is a trauma paper. Okay, that's for time. One's a trauma paper. That's actually the first paper we wrote on this. So this is an Archives of Surgery, which is now JAMA Surgery, about surgical informatics. It's a single center pre-post study. And here's like the one picture that you need to see. The big red line is the before versus after. We were ordering appropriate prophylaxis about 60% of the time. The decision support tool got us up to about 85% of the time. VTE moved in the right direction, although not statistically significant because of numbers. And then our preventable harm went to 0 for 2 years, and then we had one uptick with statistically significant decrease in preventable harm from VTE with this decision support tool. We then did a similar thing on the internal medicine service, same idea, pre versus post. Optimal prophylaxis went from about 65 to 90%. And we did the same thing. Preventable harm went to 0. It's possible to get there. We didn't eliminate every single VT event. There were still patients getting prophylaxis and getting a breakthrough event, but preventable harm, patients getting an event without getting prophylaxis that they should have, 0. So we can make a goal, we can make a difference. We won this nice little award. We got a little big plaque. John Finicos, is that you? John Finicos gave us this plaque. Yeah, so this is a few years ago from the NATF. And then AHRQ used this as an example that we're not the only ones using clinical decision support, but this is a great example of how you can use clinical decision support embedded into your project or into your EMR. We got a nice little big golf check from the CDC for the project as well. So you can use decision support to make change. So if you notice, we got to about 85%. So that's like a solid B. For kids, you have kids in school, that's a solid B. You want them to do better, you want us to do better. So we decided we were going to try to do better. So we were going to do a little bit of, harness the analytics. We have the data, it's in the computer somewhere, we're going to use that data. We're going to use a little bit of gentle, friendly competition to see if we can improve care. So we decided we're going to start on the trauma service, and I'm going to compare me to my trauma partners. Turns out, my trauma partners and I, in these dark blue bars that you see, are all statistically indistinguishable. We're all the same. Why? Because we don't click on the order set. Andrew Bernard's like, I don't know how to do the order set. Absolutely. So who does the order set? The interns and the residents. So each of those bars is an intern or a resident over the course of a year. 7 residents, never ever, over the course of the whole year, followed the recommendation of what they should give. Okay? 42 residents followed it 100% of the time. And then there's a smattering in the middle. So what did we learn from this? Don't give feedback to the attendings. We're not the ones doing it. You need the frontline clinician actively doing the orders. So that's where we started to give this feedback to our residents. So we started it on October 1st. This was a resident quality improvement project. This paper was co-authored by an informatics, at the time, research assistant I had, and one of the surgery residents. We started on October 1st, and we gave them data. Each line is a resident. They knew who they were. They know where you were compared to all your peers, and we gave out the data. This is September's data, and we gave it to them on October 1st. And it went to October. We moved from 87% overall to 93%. By November, we moved to 96%. Rapid change. Want to know why? Because nobody wants to be at the bottom. Nobody wants to be that last one, and nobody wants to be red if all your peers are green. You want to know what it looks like over the course of a year? Or 15 months, here's what it looks like. The July effect is real. We didn't educate enough about it. We gave them some feedback and mitigated the July effect. So if you don't believe in the July effect, there it is. But this improves the process and hopefully is improving the outcome. So we've heard a lot about missed doses of VTE prophylaxis. It's been mentioned a couple different times by a couple of different speakers. We're going to talk a little bit about that now and a little bit more about that tomorrow. So there's this big assumption that as physicians, we were working, all that stuff I just explained was physician-based. We're going to get the doctors to write the right prescription, and then magically the world will be cured and there'll be no more clots. But does prescription equal administration? And it turns out the answer is no. And a few people have already mentioned that. So there are these steps, and AJ is very similar to what AJ showed us. The provider has to do a risk assessment, prescribe the right medication. The nurse has to give it to a patient who accepts it. All those steps along the way are absolutely critical. So this paper was already mentioned earlier. This is probably one of the first papers that really showed the association between missed doses of VTE prophylaxis and VTE events. This is a trauma and general surgery population. We looked at this at our single hospital, as it goes to AJ, your point about public reporting. So this is data for 1 year from our hospital that's publicly reported to Maryland and used in our MHAC program, Maryland Hospital Acquired Conditions. It's our pay for performance in the state. About half the patients of the 92 patients with events had defect-free care. We called that a risk assessment, the appropriate order, and got every single one of their doses. So the first thing to learn is we're being penalized as a hospital for pay for performance for giving perfect care, best practice, for half of the patients. So that's the first part, okay? The second part is we weren't perfect, and the other issues were we either had inappropriate prophylaxis ordered, that's about 15%, or about 40% of patients who are missing doses. This isn't certainly not the strongest research design, but it gives you a feel for what the numbers look like. We did a small study. I say it's small because we've now done larger studies with bigger numbers. 100,000 doses of prophylaxis at our hospital. About 12% are not administered. Number one reason is patient refusal. We're going to talk about that again later. So is this different than other medications? Absolutely. And we've done a few other projects that missing VTE prophylaxis, it's not because patients miss every other med in the hospital. When you compare it to all other medications, other types of prophylaxis, other types of things, there's this giant bar, and VTE prophylaxis is just different. Probably part of it is because it's injectable. That's probably not the whole story. Here's data from across our health system. It's not just unique to Johns Hopkins Hospital. Other people have mentioned it already at their institutions. Here's what it looks like across our health system. Our academic hospital had improved from about 12% down to about 11, maybe a little difference. Our community hospital is around 13%. So it's not just at our one place. So at some point, you got to go to the patient, you got to talk to them, you got to understand what it is. It's not just numbers like Peggy Knudsen just said. You got to go and see. So we did a mixed methods, qualitative, quantitative survey of nurses and observations. We sent a pharmacy resident out to go observe these interactions. And this is one of the questions from the survey of nurses. I have the clinical knowledge and experience to determine if it's necessary to administer prophylaxis to patients. 87% of medicine nurses and 79% of surgical nurses agree to that they could just, Andrew Bernard's like, whoa, I can't believe it. And you know who else was shocked? The nurse who'd worked with us for years, who'd worked in the ICU for 25 years, the nursing director, everybody. Like, really? That's ridiculous. This is a medicine should be given every single time. We went and got quotes. This is a pharmacist talking to nurses, watching the interactions. Things like, I push harder for certain patients to get DVT prophylaxis. Or sometimes if it's the middle of the night and it's the only medicine, I just won't wake them up to give it. Stories like that. Stories like this one, we make the decision all the time about whether they need VTE prophylaxis based on ambulation. Hey, we heard stories about STDs also. Oh, the STDs are on, they probably can miss a dose or two. Or if you're up high-fiving me in the hall. This is where you got to go to the front and figure out what the real story is. The data would never tell you this until you actually listen to frontline people. So we actually busted that myth. We were talking at lunch. All good research comes from spite. So when people say things like, oh, they're ambulating, they're walking, they're whatever, no, that's actually not true. And Pat Murphy, where's Pat? Helped with the systematic review meta-analysis, tried to do a meta-analysis. There's no data that ambulation works, right? It's not that we should we're saying you should lie in bed all the time and never get out of bed. But we don't want people to think, well, if you're ambulating, you don't need all these other things. A little bit of spite goes a long way. So then we got some funding from PCORI. We were working and engaging with patients. These are the main objectives of our initial project. So we're going to talk about patient-nurse communication, empowering patients, and then active management with this real-time alert. I'll tell you what that looks like in a minute. We collaborated with a bunch of organizations. You're going to hear from Leslie Lake, who's a patient and an advocate and is representing the National Blood Clot Alliance. You'll hear from her later this afternoon. You can go to the website and hear more about it. You can go to Wall Street Journal, read more about our project. And so we did one piece, based on that feedback from nurses, the nurses we thought needed some education. So we built some education for them. Originally, we were going to do death by PowerPoint. That was our only option. That's what we do, right? And you've all done this. You make the slides, you do a voiceover, and they have to go watch it. But at the time, then we had a guy who came and said, no, that sucks. How about I build you this really cool, nice, interactive model for education? So we took it. We actually randomized nurses to both of those different options. We studied in a cluster randomized trial, 10 surgery floors, 10 medicine floors. The primary outcome is not did you like the education or did you take a test? It's how many doses did you give after you took this course? Did you do better? And the answer is doing this one online module takes less than a half an hour and VT prophylaxis by about 12%. And as a bonus, the nurses love the nice interactive one better. So that's what we use now. If you have people that want to go take it, here's where you can go take it online. So now we taught the nurses, and now we got to get to the patients. So we actually asked them what they wanted. Shocking. Instead of just telling the patients what they wanted, we did a survey of patients. We worked with these organizations, got 400 responses, and got the impact or the input from patients of what they wanted to hear, who they wanted to talk to, how did they want to hear it, are they willing to watch a video, et cetera, et cetera. And we took that information of what they actually asked for, published a paper on it with 2 patients as co-authors. Those are the red circled people, both pulmonary embolism survivors. And, did some in-person meetings with these groups and put together a patient education bundle. This is all freely available. You're welcome to use it any time. I can tell you where to find it. You'll see in 2 seconds. So there's paper education materials. It's 2 pages. That's what patients said they would read. It's the front and the back. It's translated into numerous languages. I posted this. Somebody said, well, why not Urdu? I said, well, it wasn't on our top 10 list, and we added it in, and now you can get it in Urdu on our website. They wanted a video, so we made a video. We hired a guy who'd won an Oscar for a documentary, and we're in the film. So you can go now watch this video. We've shown it to patients. It's been viewed 275,000 times on YouTube, right? For a patient education video, that's a pretty good number. So now we have the materials and we have the nurses educated. We're going to do an intervention with this bundle of education. So here's what we did. We published it in JAMA Network Open a couple of years ago now. We have a real-time alert. So what happens is, the nurse documents Mr. Smith didn't get his dose at 10 a.m., and there's a real-time alert that goes out. We have the SWAT team that comes in and educates the nurse and the patient in real time. And here's how we set up the study. So they have the bundle, the paper, handout in your preferred language. Here's a video. Here's an iPad. Watch the video, and a one-on-one discussion with the person. And we did an intervention versus control floors, and here's some data from that. So you'll see on the intervention, on the control floors, nothing changed from pre to post. On the intervention floors, nearly a 50% reduction in any missed dose overall. And then when you look at refused doses, same thing. Control floors, no change. Intervention floors, almost a 50% reduction in missed doses. The intervention works. Makes a difference. So I'm going to close out with this topic of defect-free care. It goes a little bit back to AJ Malhotra's talk this morning. Here's the paper we wrote in Circulation a few years ago. And it's this concept that defect-free care is we're pushing a risk assessment plus prescription of optimal, appropriate, best practice prophylaxis plus administration of every single dose that they're supposed to get. That's defect-free care. And we should be providing that to every single patient that comes in the hospital, whether it's a trauma patient or any other sort of patient whatsoever. And this outcome measure, we could measure patients who are provided defect-free care. If you missed any one of those steps, that's a defect that we should try to be fixing. So with that, I'm going to end with, changing practice is a team effort, and I'm the one here getting the talk, but I always like to show pictures like this. I think that's our second BT symposium. Bill Gertz is our visiting professor in the back. The one on the top left, those 4 patients, people sitting at the table, are patients. Every year at our symposium, we have patients who come and tell their stories to remind us of, like when Peggy Knudsen said, the patient dropped dead, or you'll hear Leslie's story. You got to hear from the patients. So we have patients who come and speak to us every single year. And then I ask this question, and it might be a little skewed audience. Anybody here ever been to a breast cancer walk? Come on, raise your hands high. Okay, for those of you online, 50%. Okay, raise your hand. Anybody here ever been to a blood clot walk? Me and Leslie. Okay, so advocacy, outreach, public information, super important. You guys all care a lot about PTE, and even you haven't been to a blood clot walk. So we just have to change our perspective a little bit. So with that, I'm going to close. I've got a bunch of websites here. You can email me, you can find me, you can tweet at me. I left my phone down there. I don't know how we're doing on time for Q&A. Leslie, please use the mic. Oh, thanks. Use the mic, and if you can announce your name for the people online, just a reminder so they know who's speaking.
Okay, does this work? Yes, okay. I'm Leslie Lake. I'm the volunteer president of the National Blood Clot Alliance. Elliott, I'm curious, the numbers of the intervention, when you said intervention work, and clearly from the data it does, is that an ongoing process, or is that you reintroduce on an annual basis? Like, how do you maintain those numbers?
So the education for the nurses was a one-time gig. We did this intervention as a research project, and we had a nurse educator who was paid for by the Corey doing the interventions. In tomorrow's talk about implementation science, you're going to hear part 2 and the continuation of that project and where we are now and how we've grown that since then. So if you don't mind, I'm going to hold off till then. Dr. Stein.
Elliott, thank you so much for an amazing talk and an amazing body of work. My question for you is about, you obviously have the implementation thing down. How do you, number 1, sustain, and number 2, prioritize? So we found, for example, at our hospital, we had a big CLABSI problem. We spent all this time and energy into our reduction of our CLABSI rates, and our sacral pressure injury rates shot up because there's only so much time in the day. How do you prioritize, how do you sustain, and how do you prioritize?
A great question for those of you who couldn't hear it. How do you continually play whack-a-mole in quality and safety when, something comes up and you whack it down and then something else is over here again? It is really, really hard because, and as AJ was mentioning, there's a million things that get measured. I'll put on my hat as a vice chair of quality for the Department of Surgery. There's a lot of things that get measured. CLABSI, CAUTI, unintentionally retained foreign objects, et cetera, et cetera. I mean, it's hard to do every single thing. And in some ways, the options are do a little bit of each one, but do a focused thing here for now. And then when you move away, you got to have some sustainment plan. And the sustainment is, I find, the really hardest. It's relatively easy to do a project when the hospital president and the vice president for medical affairs and the chief quality officer and the chief nursing officer all say, CLABSI's a problem, we look bad, we're losing $10 million, fix it. That's relatively easy to garner resources. What do you do when you fixed it? Now you're like, we want to keep those things going, but now they want to move those resources, and the resources are, money, but also people time to do other things. And then your CLABSI rate goes up. I don't have an answer for it. It's really, really, really hard. I think the more we can automate things, the better. Once you've built it in and automated it, then maybe that automatically improves things. So this intervention where you put something in your EMR, make a change, and then it keeps going is great, assuming somebody checks in on the data once in a while to make sure it hasn't, gotten worse. They changed the EMR and your thing got deleted. They changed the name of your floor and now these two floors are together and you lose their data. I mean, I speak because every single one of those things has happened to me. It is a hard question to answer.